crap. John, I accidentally muted you. Try to silence everything.
Okay, well, welcome. I'm glad we were able to have this meeting while in the safety and warmth of our homes. Tonight's topic is an important one because of the potential for serious consequences of falls caused by balance problems or dizziness. Before we get started, I have a few instructions for those of you who are not experienced users. If you look at the bottom of your screen, you see a button to click on to see closed captions provided by our wonderful captioner. It says live transcript, and Lauren Schechter is providing the captions. Please also click on mute so that we don't hear background noises such as sirens and dogs barking in your house or apartment. We have many new faces here. I would like to welcome all of you, new members as well as non-members. In this virtual format, it's difficult to get to know new members, but please feel free to reach out to me if you have questions about the HLAA or audiological services. My email address is jtaylor@hearinglossnyc.org. I should also mention that we're recording this. When the recording is ready, we will post a YouTube link on our website for others who've missed it tonight. Before we get to our speakers, I'd like to take a quick poll about how you heard about the meeting. David? David, can you post the poll? Do you have the results, David?
I do.
Okay, can you show us?
I think so. Does that work?
Interesting. Okay, thanks for that. At the end of the talk tonight, if you have a question of any of our speakers, please type it into the chat box. You can actually do that while the talk is going on. At the end of the presentations, I will read aloud as many questions as we have time for. I got a preview of the slides, and I think this is going to be a very interesting educational presentation. Even if you aren't posting questions, you should keep the chat box open to avoid the orange chat icon popping up and covering the captions if you're using them. If you prefer not to see the chat, you can drag and drop it to the side outside of your screen. Tonight, we will hear from Dr. Maura Cosetti, a vestibular therapist, from Jennifer Kelly, Jennifer Kelly is a vestibular therapist, excuse me, and from a nurse practitioner, Andrea Feghali. They'll talk about the causes of and diagnosis and treatment of balance problems and dizziness, as well as ongoing research and exercises aimed at treating these problems. Dr. Cosetti is the director of the Ear Institute at New York Eye and Ear of Mount Sinai and an associate professor of the departments of otolaryngology, head and neck surgery, and neurosurgery at the Icahn School of Medicine at Mount Sinai. She has authored more than 50 articles and chapters and presented at various national and international specialty meetings. Her clinical interests and expertise include pediatric and adult hearing disorders, cochlear implantation, Meniere's disease, quality of life metrics, chronic ear disease, and otosclerosis. Current and ongoing investigations include treatment for hearing loss in children and adults and auditory implications of sensory integration, for which she currently receives funding from the Hearing Health Foundation and the National Institute on Deafness and Communication Disorders. Dr. Cosetti is also the primary investigator for multiple industry-sponsored research trials involving cochlear implantation and novel intratympanic drug therapy. Jennifer Kelly has a doctorate in physical therapy. She's a neurological clinical specialist and the supervisor of rehabilitation services at the Ear Institute of the New York Eye and Ear Infirmary of Mount Sinai. She has been a physical therapist since 2002, practicing exclusively in vestibular rehabilitation since 2007, and became a neurology board certified physical therapist in 2009. She has presented nationally and internationally on dizziness and postural control related to vestibular disorders. Dr. Kelly is involved in clinical research at the Ear Institute with the goals of understanding compensated and uncompensated behavioral patterns of vestibular loss and to understand the importance of auditory cues for balance and their clinical implications. Andrea Feghali is a nurse practitioner at the Ear Institute of the New York Eye and Ear Infirmary of Mount Sinai. She completed her bachelor's degree in nursing at NYU before working as an RN at New York Presbyterian Medical Center. She later returned to NYU to earn her master's degree to become a nurse practitioner. Her clinical interests include otologic and vestibular disorders. She has participated in various research studies focusing on Meniere's disease, the relationship between cognition and hearing loss, and hearing preservation following cochlear implantation. Andrea works closely with neurotologists, audiologists, and vestibular therapists as a team to provide patient-centered care and treatment of patients with otologic and vestibular disorders. Dr. Cosetti, will you start us off?
Thank you so much, Jonathan. Can you hear me well?
Could be a little louder, but we have captions.
All right, very good. Thank you so much for this wonderful invitation, and it's really wonderful to be with all of you. This is actually not what New York looks like today, just in case any of you are, I think there was someone from Wisconsin, but perhaps your Wisconsin view is about as snowy as our current New York City view. Thank you for that wonderful introduction, and just a thank you to David Landsberger for hosting this and doing the poll, etc. It's really wonderful to be with all of you, and I think we typically see a lot of you on the walk every year, but nice to be with you this evening. That was about as thorough an introduction, I think, as I've received recently. Just to say again, I'm Maura Cosetti. I'm a neuro-otologist, that's just the E of ENT. I'm a surgeon, and I'm joined tonight by Andrea Feghali and Jennifer Kelly, who you heard a lot about, and together we have a team that's going to talk to you about hearing and balance with a focus on balance. We have a pretty big outline for this evening, so we wanted to put in something for everyone. We're going to start out with just some basic anatomy and physiology. As a surgeon, I just love anatomy, and frankly, I find that's the perfect place to start. Then we're going to talk about one of the most common balance problems that affects a great majority of individuals. From that point, we're going to transition to a little bit of research. So for the researchers out there, or for anyone interested in some of the research we're doing, we're going to spend some time talking about that and finish up with some treatments with a focus on something called vestibular rehabilitation and balance exercises. We have a whole bunch of videos throughout this presentation, and we really look forward to your questions and any comments that you might have, which we can, per Jonathan's instructions, go through at the end. So I'm going to hand this off literally by standing up and letting Andrea Feghali take the wheel here.
Hi, everyone. My name is Andrea Feghali. I'm a nurse practitioner at the Ear Institute. Happy to be here. Thanks for having us. So I'm just going to start off by going over some basic anatomy of the ear and then go into one of the more common balance problems that we see. So here, this is a diagram of the basic anatomy of the ear. As you can see, it's divided into three sections: the outer ear, the middle ear, and the inner ear. The outer ear includes the auricle and then your auditory canal or the ear canal. Then you'll find the tympanic membrane, or your eardrum, which separates the outer ear to the middle ear. The middle ear includes the ossicles, or the bones of hearing. We have 3 of them, the malleus, incus, and stapes. And the middle ear also includes the eustachian tube. It's the tube that connects the back of the ear to the back of the nose. And finally, we get to the inner ear, which has the cochlea and our vestibular system. Okay. Sorry about that. Some tech issues. All right, so here we have the inner ear. In fact, to give a sense of scale, the entire inner ear, including the cochlea and the semicircular canals, can easily fit on the surface of the penny. Unlike many structures of the outer and middle ear that we discussed earlier, the inner ear is actually adult size at birth. So just as we have hearing in both ears, we also have a balance system in each inner ear. Within each balance system, we have tiny organs that are used for sensing rotating and non-rotating motions, such as side to side or up and down. Sorry again. Okay, so now we made it to the inner ear. Our balance system is made up of the semicircular canals and the otolith organs. The semicircular canals, pictured here, are tiny fluid-filled tubes or canals. They are responsible for providing a sense of directional balance. For example, just nodding your head, yes or no, side to side, or tilting your head right to left. The balance system is wired to our eyes, which helps us maintain stability when we walk and move. So the inner ear helps us coordinate our eye movement and our head and body movements, and we'll discuss that further on in the presentation. One of the most common causes of vertigo, called BPPV, occurs within these canals. So BPPV stands for benign paroxysmal positional vertigo. So benign is not malignant. Paroxysmal, it occurs suddenly, it's temporary, it can come and go. Positional is usually triggered by position change, and vertigo gives the sensation of that you're spinning. So what is happening in your balance system when you get BPPV? As we mentioned, our balance system is made up of these semicircular canals and these otolith organs. Within these organs are tiny calcium crystals, which we also call otoconia. When these crystals get dislodged or displaced and start floating around these canals, the patient will experience the severe vertigo or sensation that everything is spinning. And you can kind of see in this diagram when the patient is just standing up, the canals are kind of getting ready to move, and when she lies back, they'll be free floating, and that's when she'll get dizzy. So 30 to 50% of dizziness in older adults is caused by BPPV. Older adults with BPPV have a greater incidence of falls, depressions, impaired ADLs, and we'll go over that a little later on in this presentation as well. BPPV can also present with falls and postural dizziness rather than the classic presentation, and it is more prevalent in women than in men. So there are many different causes of BPPV. One could be head trauma, age-related degeneration of the vestibular system, which again we'll talk about later on, osteoporosis, ototoxic medications, those are medications that could be toxic to the inner ear, migraines. Migraineurs actually have a 7.5% increased probability of getting BPPV. And over 50% of causes are actually idiopathic. So we don't know what causes them. It can occur spontaneously. So BPPV can be confirmed as a diagnosis by a maneuver called the Dix-Hallpike. You can be seated on a flat surface like this in this photo. Your head will be turned at a 45-degree angle, and the provider will ask you to keep your eyes open and your neck relaxed throughout the maneuver. You will then go from a seated position, which you will see on the next slide, to a lying down supine position with your head resting in the examiner's hand. Your neck will be slightly extended off the flat surface, so your chin is pointed slightly upward towards the ceiling. So now you can see the patient is in that supine position. If you do have BPPV, you will get dizzy in this position, as those little crystals, or otoconia, will be free floating from one end of the semicircular canal to another. But don't worry, these symptoms of vertigo will subside usually within seconds. There is no quick pill treatment for BPPV, and while many cases resolve untreated over time, a vestibular physical therapist can help treat your symptoms by performing certain exercises, which will be discussed later on in this presentation. And now Dr. Cosetti will be talking to you about other components of balance in addition to some current research.
Thanks, Andrea. That was a great overview of the balance system, and Andrea helps us with a lot of our evaluation and treatment of a lot of our dizzy patients. So now we're going to move from the ear, because actually the ear is only one part of the balance system. In fact, the balance system is pretty complicated. It includes vestibular input, such as that coming from the inner ear, something called proprioception, which is basically how our brain knows where our body is in space. And the proprioceptive system includes both our muscles, sometimes called the somatosensory system, as well as nerves. Major nerves like our spinal cord, as well as nerves in our feet and other things we use to connect with our environment. Of course, it also includes vision, and we're going to get a little bit to what this other category is. All of this input is basically taken by our cortex and brainstem nuclei and another important part of our intracranial cavity, our cerebellum, to ultimately result in posture, balance, and various eye movements to keep our body and our head looking where we want it to be. So, in fact, standing is a basic human function that most of us take for granted. However, in reality, it's pretty complex perceptual motor process. So one, we have to sense position and motion, and we get that sense from our vision and the somatosensory systems, as well as our inner ear. We then need to process that sensory information to determine orientation and movement, and we need to select various responses that maintain or bring our body into balance or equilibrium. And you'll notice that on the prior slide, I didn't include something, and that's the auditory system. So this is an important question that we're going to now get into in this brief period of, let's call it the research section of this presentation. And in this section, we're going to talk about if what we hear matters for our balance. So maybe this is something that's pretty germane to all of you, or something that you've heard of, which is in recent years, there's been a lot of research into the impact of hearing loss. And it turns out that hearing loss may relate to some other things, such as some people have talked about cognition and is it related to dementia. And today we're going to talk about falling, as you can see here. So just to speak generally about falls, for those of us, such as the three of us in this presentation, who are in the hospital, working in the hospital all the time, falls is something that we think of a lot. Falls are a really big deal. 20 to 30% of adults over the age of 60 suffer a fall each year. Many of these are non-fatal. However, 1 in 5 of those non-fatal falls result in a pretty significant injury, like a hip fracture or having a traumatic injury to your head or a concussion. And in addition, of course, there are some fatal falls as well. All of this leads to a pretty large economic impact, as you can see estimated here. Turns out that through a bunch of research, we're going to characterize this research in just a minute, it seems like there's a link between hearing loss and falls. Turns out that elderly individuals, such as those over, and for this, they considered those over the age of 65 to fall into that category, have a 63% increased risk of falls compared with their normal hearing peers. When these studies were done, they were done with large epidemiologic databases. That's where they look at data over time. Many of you may have heard of the Harvard Nurses Study. That's a famous one in the US, and there's a bunch of others. And there's also same epidemiologic databases in Australia, Finland, the Netherlands, and even some in Asia, where they've looked at large groups of people, over 1,000 each, and actually found this same finding, that individuals with hearing loss have a higher risk of falling. Some of those studies even suggested that the more hearing loss you have, the greater risk of falls. Now, many of you on this call may not be surprised to know that some of the hearing aid companies, such as the Starkey ads I have right here, were the first to jump on this bandwagon. And in fact, even this Burbank audiology website, I found this this image here. And I don't think Burbank right now looks quite like New York, but certainly falling in the snow is something to consider. Now, importantly, because I mentioned these are epidemiologic studies, none of them actually included studies of the vestibular function of the inner ear. So none commented with those individuals have known problems, even including BPPV like Andrea was discussing, or other vestibular problems. However, this study then came out, and this is one I'm going to highlight, but there are others we could discuss as well, that looked at, again, a large number of patients, about 1,000. And all of these individuals had audiometric testing. They all had vestibular testing. Many included individuals with other known inner ear dysfunctions, such as vestibular neuritis or Meniere's disease. And they found this piece of data took about 12 years for them to encompass all of these individuals. And even in the presence of vestibular dysfunction, they found that hearing loss was an independent predictor of increased postural instability. So individuals with hearing loss tended to have greater balance problems with their posture and with falls. So this brings us to a primary question I wanted to bring to your attention regarding our research, which is, what is the underlying mechanism for balance problems in hearing loss? I showed you that literally across the board and across the world, lots of data suggests that hearing loss is related to falls. But why is that? Could it be because individuals with hearing loss might have some slight vestibular loss? That's something that we would call subclinical, meaning perhaps because both things, both hearing and balance, are localized to the inner ear, maybe there's an anatomic relationship there that could account for this relationship. Or is there another answer? Could it be something called sensory integration? Is it possible that we use our hearing to orient ourselves in space, or even create something called a spatial hearing map? And as something that is probably not foreign to anyone who's done or read research, maybe both of these things could be occurring and they're not mutually exclusive. So a bunch of data has emerged in the past, 5 years or maybe a little longer, suggesting something called a spatial hearing map. So if you took a textbook, the textbook would really only have those conditions that I mentioned earlier, or those senses such as visual, vestibular, or proprioceptive or somatosensory, and would include audition. But recent data suggests hearing should be included. Maybe our hearing provides spatial orienting clues, and it does so with speed and accuracy, so that we can basically create an environmental spatial hearing map. In addition, maybe individuals with hearing loss develop substitution strategies so that they might depend on other senses when they're trying to maintain their balance. This is something that's very familiar to vestibular patients and vestibular research, and I'm going to mention that in just a minute. So what do I mean by substitution strategies? Well, that's another way to think about sensory integration. So in order to maintain our posture balance in the presence of something that destabilizes us, our brain then goes to an input that it finds reliable. The scientific term for that is called weighting or reweighting. An easy way to think about that is people who have issues with their feet, like perhaps they have diabetic neuropathy or they've had foot problems, they might have a hard time on a slippery surface because their feet are having trouble sensing that ground. In fact, in that case, studies have shown that they reweight other senses. Frankly, they rely on their vision. And how about those individuals who are relying on their vision? Well, they might have a difficult time in darkness or when the vision is rapidly changing. This concept of sensory integration is something that our lab is highly focused on. And here I have a small picture of our team leader, who's not with us tonight, but her name is Dr. Lubetsky. She's actually from NYU downtown, the Steinhardt campus, and she's a scientist who runs our lab on multisensory integration for balance. And to do that, we use virtual reality. All right, so now we get to the exciting, I think they like to say sexy part of the PowerPoint presentation. And as you can see, my team who's with me tonight, we are all involved in research. This video here, and we're going to see a couple of them, is just one of the many videos that we use as part of our experimental paradigm. So our experimental paradigm is geared toward understanding why people with hearing loss are at increased risk for falls. So we basically manipulate a bunch of those different senses that I mentioned earlier: vision, hearing, somatosensory, and we do that by having people stand on foam or give them less reliable input to their feet. And we see what their substitution strategies are. We see how they weight or reweight various senses. Additionally, we're using VR in a bunch of different contexts, which I'll give you just an overview about. One of them is through vestibular rehabilitation, and the other one is to develop a really good test for the inner ear. So here's how we do it. Maybe people on this call don't use quite as much virtual reality as some teenagers out there, but if you have teenagers, or even if yourself have developed an interest during this pandemic, virtual reality has become quite amazing. Here's a picture of the Oculus Vive, which is one of our experimental setups, and this is our lab, and here's one of our patients who participated in our experiment. Now, because gaming has made such dramatic progress, many of the inherent technology that's in these devices we're actually able to exploit for getting information about things like head movement. We use a force plate and other different things to assess balance and posture in a scientific way. So here's one example. For those who may have some difficulty hearing the sound, or hopefully I did test the sound earlier, this is a street scene, and it is intentionally not real, not is accurate to real life. In fact, there's a lot of data within the gaming industry, and I didn't include a lot of people. I didn't mention our other important collaborators in our research lab, which include a lot of other people from the NYU downtown campus who basically are computer programmers and auditory technicians. Many of them actually go on to careers in the virtual reality world, such as gaming and other things. And the data in that says that if you make a setup such as I have here, hyper real, individuals who are participating actually pay attention to the parts that are different from real life. But if you make it very generic, you're able to manipulate the senses and give people the feeling of being in a situation without having them get the anxiety or some of the other responses that might occur. So this is a city scene. And in general, a lot of the goals of our research are to mimic various scenes. The city scene, as you see here, and the airport scene, which is the one I showed on a prior slide. In these experiments, we put 3 groups of people. One group are controls. So if you're a student at NYU or a student at Mount Sinai, you may have been in this group. The other 2 groups are individuals that have vestibular problems, diagnosed problems with their inner ear balance system, and those with hearing loss. So if you look at this graph, you can see that the 3 lines are quite different. And frankly, that alone is pretty interesting. The control group, whether or not we added the sound or whether or not we added a lot of people or a little people, they did pretty well. But in fact, the vestibular group, which we have in red, and the hearing group had some difficulty. The vestibular patients had the hardest time, and that's not surprising. We expected that. But actually, the hearing loss patients had some difficulty as well. And these are individuals that do not complain of dizziness. they don't have any known inner ear vestibular dysfunction. This is another feature of the virtual reality headset where we can tell where people are looking. We tell people, just look straight ahead. Just look straight ahead in these various scenes. This is particularly a stars scene, so this one doesn't have any individuals moving that I'm demonstrating on the pictures here. You can see the control, that's a young student most likely, although we do have a lot of age-matched controls. And these are individuals with unilateral hearing loss and those with unilateral vestibular weakness. So first of all, you can actually see that these heat maps are very similar and a lot bigger than this one. So there's a lot of movement in individuals with hearing loss and vestibular dysfunction.
Excuse me, Dr. Cosetti?
Yes.
This is John Taylor. I'm sorry to interrupt you for a second, but many of the people in the audience have hearing problems, and it would be great if you could slow down a little bit. We're having a hard time keeping up with you, and we don't want to miss anything.
Absolutely, Jonathan. Thank you. I have a reputation for speaking very fast, so I will do my best. In this particular slide, I'll give a quick summary, which is controls, those without any hearing and balance problems, had trouble keeping their head still. We know that because when we tracked their head position and tracked their gaze, it looked very different for those with unilateral hearing loss and those with unilateral vestibular loss.
You turn me inside and round.
This video is actually from, I think, a Mercedes-Benz commercial, and it's trying to demonstrate how the car may move all around, but the shocks of the car don't allow that movement to translate to the driver. And it's a great analogy for head movement and body position. Well, why is this important? It turns out that head movement may be quite different than posture and body movement. And that's important in our experiments because we've noticed that head movement is very specific for people with an inner ear vestibular problem. In fact, posture or balance can be abnormal in people with vestibular problems or in people that have had a stroke or people that have heart problems. So that body movement may not necessarily be specific for an inner ear problem, whereas head movement might. And so part of our goal is to figure out if our headset can not only ultimately help us treat through vestibular rehab, but can give us a great test for inner ear balance function. These are some graphs that demonstrate someone who has no hearing loss or vestibular problem barely moves their head at all. But individuals with hearing and balance problems move their head a lot. That's demonstrated by this big oval, which tracks the path of their head movement during a given period of time that we're measuring. So this brings me to our last aspect of our research, and that's using this virtual reality headset to help us with something called vestibular rehabilitation. We like to call this VR for VR, or virtual reality for vestibular rehabilitation. You're going to hear from one of the best vestibular rehabilitation specialists a little bit later, Jennifer Kelly, who's going to go over some specifics of vestibular therapy. But it would seem pretty obvious that if you're off balance, either from an inner ear problem or something else, you would get anxious and dizzy and nervous in areas that are noisy or visually complex. Frankly, as New Yorkers, everywhere is noisy and visually complex. Subway, I have Times Square here. These are pre-COVID pictures, obviously. But how could virtual reality help us there? Well, the concept of making some therapy just like the real world is not a new one. This is actually taken from the 90s, where they had this picture of something that looked like a supermarket. And really good evidence says that training in something that looks somewhat like reality might be more effective. So here's an example of one of our subway scenes. This is actually supposed to be the upper part of the subway. We have one that also has a train going by, which is a lot of fun. So as many researchers may comment, and I have certainly learned, you learn the most from your patients. So when we originally did this, Jen and some of the others found that their patients told them, you know, this virtual reality research study you put me in, I think actually helped me. I felt less overwhelmed when I was walking in the street, and gosh, I felt like in real life, I would have been really bothered by walking with all these people around, but I think practicing it during the research study actually made me feel more comfortable. So like many great ideas, this particular part of the study really came, and a lot of research, directly from patients that were experiencing it. And we're finding with a lot of data that it's actually quite helpful. Now at this point, I'm going to turn it over to someone who's a much slower talker than me, Jennifer Kelly.
Hello, everyone. My name is Jennifer Kelly. I am a supervisor of vestibular therapy at the New York Eye and Ear Infirmary, and we're going to talk about what is vestibular rehab. Oh. Hold on. Great. No, I got it. Yeah. So this is an evidence-based exercise therapy, which addresses balance and dizziness in people with inner ear problems or people with multisensory balance impairments, which we'll talk about in a little bit. All of the exercises that we do focus on what the vestibular system does. So a lot of things include eyes open and eyes closed, because that challenges the vestibular system itself. Changing your base of support. So are your feet further apart or more narrow base of support? And what Andrea had alluded to, turning your head. So anytime you have to move your head, whether it's standing still or walking. And the research out there shows that there's an improvement in quality of life and decreased falls in patients with vestibular loss that do vestibular therapy. So what are some of the common symptoms of patients who have a vestibular problem? So I just wanted to highlight here in the picture of just what that vestibular cochlear nerve looks like and how closely integrated the vestibular or the balance portion of the nerve and the cochlear or the hearing portion of the nerve are. So a lot of times these two go hand in hand. So what are some of the symptoms that the patients that I see and we all see complain about? And I think it's really important if you're going to your doctor or healthcare practitioner that you accurately describe what you're experiencing. So this is where it becomes really important to determine if you have vertigo, which is the actual room spinning, or if you have dizziness, which you can see listed here. There's a lot of different ways to describe what dizziness is. And this is a very subjective term. So it can be heavy-headed, lightheaded, a swimming sensation, a foggy feeling, or just an overall difficulty with focusing. And so these are all things over the years that my patients have told me that they experience. And again, you're also going to see imbalance. And this can also, anytime you have a vestibular problem, this can occur with hearing loss. So Some of the common ones are Meniere's disease and anything, something called labyrinthitis, which is when you get a vestibular loss and a hearing loss at the same time. So what is a multi-system balance impairment? So Dr. Cosetti and Andrea talked a little bit about what balance includes. So we talked about vision. So some of the things that we think about for vision that are important that can influence your balance are glaucoma, cataracts, any problems with your retina. All of those can influence your balance. And the vision is the first thing that we use for our balance. The first thing we see, and that's the first thing our brain uses. The second thing that we talked about is proprioception, which is just the sensation in your feet. So this is being able to feel the surface you're standing on. So are you standing on something hard, soft? Is it grass? Are you standing on a ramp? Is something tilting up or down? So this commonly is impaired in people with diabetes or anyone who has any low back pain with any kind of nerve involvement. So sciatica is a common term that you will hear. And the third system is what we've been talking about, vestibular or inner ear. So a lot of things that we think about with inner ear problems, again, changing position, turning your head, walking on uneven surfaces, any kind of dark environment. So at night or when you have the lights off, particularly going to the bathroom at night tends to be hard. So some of the other things that I think Dr. Cosetti highlighted was you have to have good strength, range of motion, and more we're finding that hearing is actually one of the things we need to think about when we talk about a multi-system balance impairment. So just like you can have presbycusis, you can have progressive age-related vestibular loss. And many times this is undiagnosed. So it's a slow and progressive loss over time that maybe you might not notice. You might not be dizzy, but you just have imbalance. The common complaints that we see are imbalance, difficulty crossing the street. So when you have to turn your head, look at oncoming traffic, look at the light, can't walk and talk to someone. So that also includes turning your head. Dizziness with moving your head or changing position, and stepping on and off of curbs or walking down a ramp. The important thing, and this is what I learned when I started doing this from my patients, is when you have a hearing loss, it tends to be even more important that you can move your head. And that way you can localize the sound. So if you have a hearing loss and a vestibular problem on top of that, it can become really hard to move your head. So we're going to go into examples of some of the exercises. Always like to give a disclaimer that these are examples and follow the guidelines of your healthcare provider before you start any exercise program. So here we have Andrea. She's our model for the day. And so this is one of our first and most common balance exercise that we give patients. So this is a standing still with your eyes open and feet together. And you can see she does pretty well with this. And I always tell patients to do this in a corner or somewhere where if they feel uncomfortable, they can put their hand out and reach for the wall. So the next one we're going to do is standing with your feet together and your eyes closed. And so I want you to look and see the difference between eyes open and eyes closed for Andrea. And you can see here she starts to sway a little bit more. And that's natural. Everyone is going to do that. When you close your eyes, you become more heavily reliant on your vestibular system or your inner ear. And so this is a great exercise to do if you have an inner ear problem. So what we just showed before are just feet together. So you can make it more challenging by staggering your foot position. And so here, she's in what we call a half tandem position. And she'll have her eyes open. Again, you can see this is slightly more challenging than just feet together. And so here she's going to do the same thing, but with eyes closed. Oh, I just played it again, sorry. Let's try this. Here it is. There we go. And so she'll be the same position with eyes closed. And again, you can see that she has a little bit more trouble. So it's natural to sway more in this position. So the next set of exercises that we typically do with patients is walking and turning your head. And this tends to be really important for patients, especially who live in urban environments like we do, where you have to cross the street or scan your environment as you walk. So you'll see she's going to walk, turn her head in both directions. I'll just play that one more time. And then, so now she's going to do the same thing, but she's going to look up and down. And this is important again for our patients who need to look up at a building or read a sign as they walk down the street. And I have a lot of my patients tell me, oh, I can't do that. I can't walk and turn my head at the same time, or I can't walk and look up at the same time. I have to stop or else I'll fall over. And lastly, this is a stepping exercise that we do. So you can see she's going to change direction and step over an object. This is also a test that you can do and that we do with patients in our research that Dr. Cosetti spoke about. And we time patients how long it takes them to do this. And this is actually an indicator of falls, not only in vestibular patients, but also in community dwelling adults. We're doing this in all our research, and we're actually looking to see if that correlates as well with hearing loss. And hopefully we will find the answer to that. So we've talked a lot about falls, and I think this is just a diagram that tells you there's so many things that go into falls. There's vertigo, there's weakness, there's medication, there's environmental hazards. So a lot of falls, you know, we can't do anything about, they're unmodifiable, but some of the things we can modify here. There's drop attacks. Orthostasis is when your blood pressure drops as you stand up. We've talked about gait and balance impairment, dizziness, vertigo, and weakness. So I thought I'd talk a little bit about what the CDC guidelines are. So risk factors include lower body weakness, vitamin D deficiency, difficulties with walking and balance, the use of certain medications, vision problems, which we'll talk a little bit more about, and we already talked about in terms of glaucoma and cataracts. I want to highlight here foot pain or poor footwear. So a lot of patients come in with wearing shoes that are not the right size. So they're either too big or too small. Also, people tend to wear flip-flops or house slippers that have no back on them, and those place people at risk for falls as well. Some of the home hazards or dangers include broken or uneven steps, and we all know that on the streets of New York, everything tends to be uneven and broken up. And then throw rugs or clutter that can be tripped over. And those are things that you can easily do, picking up throw rugs and making sure that no cords are around that you can trip over. And again, we're finding out more and more that hearing loss plays a role as a risk factor for falls. So what can you do? So some of the things that you can do is talk to your doctor or your healthcare provider, and they can evaluate your risk for falling. You can also talk to your pharmacist. A lot of your medications can make you dizzy or sleepy, and this can include over-the-counter medications as well. Do strength and balance exercises. One of the things that I love to tell my patients to do is Tai Chi. It's something that you can do at any level, and it's really wonderful, especially for patients who have vestibular problems. And there's a lot of evidence out there that it works and reduces fall risk. And we're going to talk about eyes checked on the next slide. So having your eyes checked is extremely important, at least once a year by an eye doctor. And not only do you want to do that, but you want to update your glasses if you need it, or contacts. And so I wanted to show this picture of what the difference is between a single vision lens, so just distance or just reading, and some of the other lenses like a bifocal, a trifocal, or a progressive lens. And bifocal, trifocal, or progressive lenses tend to distort depth. And that can be a real problem for people who have a history of falls or who are dizzy. And that can actually increase your risk of falls or make you dizzier. So a lot of times we coach our patients to see if they can decrease to a single vision lens. So that's something also to think about when you talk to your doctor. And again, we talked about this a little bit, but getting rid of throw rugs and cords. Grab bars are really important inside and outside of your tub or shower or next to the toilet. A lot of times you might need to have, if you live in an apartment, you might need to have a super come and put it in because they need to be put in a stud. And really important is making sure your home or your apartment has a lot of light. So brighter light bulbs are really important, and night lights for getting to the bathroom. And Dr. Cosetti is going to finish up.
Well, great. Thanks, Jennifer. We're pretty much at the end of our presentation, but we wanted to finish with just some very general things, which is what to do. What should you do if you have some symptoms of dizziness? There are lots of types of dizziness. In fact, you would need us to talk for hours at a very, very fast rate to cover all the different types. Today, we talked mostly about vertigo, but there are other types, and they can be related to your heart or your eyes or other aspects that we've discussed. So the most important thing is to see your doctor. If you're experiencing dizziness or even you've had a fall and you're not sure, that's a really important thing to talk to your doctor about. Your doctor might want you to see a specialist, such as one of us. And if you do, you want to go somewhere where they have a whole team, ideally people that work on issues of hearing and balance, to make sure that you're getting all aspects of this pretty complicated phenomenon addressed. Well, very good. We covered a lot, and we really look forward to any questions you might have.
Thank you, Dr. Cosetti, Jennifer and Andrea. Can you close the PowerPoint so that we can see you?
Absolutely. 1 second. Let me just stop the screen share. Okay.
Terrific. So we do have a couple of questions here. I'm going to read them. There's a lot of talk about posture. How come no exploration of why posture is problematic in majority of people with hearing loss? For myself, posture and alignment, which affect muscles and nerves, seems the cause of these vestibular symptoms, yet sole focus is always on the ear.
Great question, and thanks for bringing that up. You know, one thing we tried to emphasize today is exactly the point you made. The focus really shouldn't always be on the ear. It's a pretty multi-system origination of problems. That's true for vertigo and dizziness and balance. And also
Sorry.
another answer.
Oh, yeah. And I think it's really important as well, when you are dizzy or off balance, our center of gravity tends to be impaired. And so a lot of times your posture becomes impaired because you don't know where your head is in space. And so a lot of times we tend to hunch forward, or because we feel so off balance, we tend to look down at the ground, right? So looking down really allows us to feel more secure. And so naturally, when we look down, we engage in that posture. The problem with that is it allows your center of gravity to come forward, and that puts you at more risk for falls. So it's kind of this endless loop that happens.
Before I go to the next question, I just want to mention that at the beginning, we had 95 people, and when I checked a couple of minutes ago, there were 99, which means that people were very engaged and stayed with us through this. So here's another question. Thank you for the wonderful talks tonight. Are there any specific concerns for folks getting a cochlear implant?
That's a great question. So obviously cochlear implants are surgery on the inner ear. That's something that I do a lot of and our center does a lot of. And obviously the person asking the question is aware. We have done and looked into, as have others, the risk of falls and balance problems right around the time of surgery. That is not common, but possible. So it's something you want to ask your cochlear implant surgeon about, whether or not you might experience an increase in dizziness or falls after cochlear implant surgery. For some of the things that Jennifer mentioned, we often talk to our patients about in the first few days after surgery, simple things like leaving a light on in the bathroom and other things just to help your environment be best prepared.
Thank you. Question here, can you talk about when hearing and proprioception are ruled out as factors and providers order MRI to look at cerebellum? If no tumor is found, what's next to think about?
Can't understand a word.
Jonathan, I think some people may be having trouble understanding. I just wanted to share that. Well, that's an excellent question. Many times an MRI is the next step in workup once you've had a number of the systems be ruled out or investigated, as this individual sounds like has had done. There are a number of specific factors that may affect the cerebellum. We didn't talk about a lot of those today, but those are typically in the realm of a neurologist. Any comments about cerebellar stuff? Oftentimes there may be specific therapies, perhaps not necessarily the ones covered this evening, that are appropriate for individuals with diagnosed problems of their cerebellum.
Okay, another question. I've been diagnosed with vestibular neuritis, and the symptoms are lack of depth perception and a feeling of being off balance. Suggestions?
Well, it certainly sounds like you're suffering from vestibular neuritis, and typically vestibular rehabilitation is a very common and effective treatment for that. I'm going to turn this over to my expert in 1 second. One thing that we've noticed is that, vestibular therapy is something that can be provided in a lot of locations, but many individuals think of vestibular therapy as just the repositioning of the crystals. And as we talked about, that's just one of many, many aspects of dizziness. So some people go for vestibular rehabilitation and tell us, well, it didn't work. Well, it's very possible that what was being done was actually not to address necessarily their particular problem. So that's something to keep in mind.
And I think Dr. Cosetti brings up a great point that not all vestibular therapy is created equal. But I encourage whoever asked the question to get some vestibular therapy. It is shown to be very effective for treating vestibular neuritis. And let me say, feeling off balance. But I also encourage, I will tell everyone, just like I tell all my patients, that it is a slow process. Recovery from vestibular neuritis or labyrinthitis, which includes losing your hearing, can take months to recover from. So it's something that you can't go one time and it be treated and you're going to feel 100% better. It entails a lot of work on your part in doing the exercises on a daily basis, because that's how your brain learns. And what we need to do is reteach your brain. And so it's important to kind of stick with it, even if you're not feeling better after the first couple of weeks.
Thank you. Is vestibular disturbance also related to migraine leading to severe nausea?
Yes. So there's a strong correlation with motion sickness and migraine. And there is something called vestibular migraine, which if any of those symptoms occur, you should really seek out a neurologist who specializes in headache medicine. Andrea spoke about BPPV, and that is the most common cause of dizziness in people, but the second most common cause is vestibular migraine. So it is more common than you think, and we see it a lot in our clinics.
Okay, here's a long one. I'm trying to use captions a lot more in addition to my hearing aids and some lip reading, but I'm suddenly having trouble with dizziness and some vertigo, which I haven't had for years. Is this maybe a brain exhaustion problem? Is it just too much to track sound, lip reading, and trying to track captions, some of which lag behind what I'm hearing? If it's a brain exhaustion problem, will it get better with practice? Or should I just back down and not juggle so many balls all at once?
Ooh, that's a loaded question. Do you want to take it? Sure. Yeah, I'll have Dr. Cosetti speak to that.
So that sounds like a great question, and it brings up another part. And sometimes when we have these, there are many more questions than answers sometimes, but concentration and memory and cognition all play a role here. In that particular question, it might be a good idea, just because I noticed that you mentioned haven't had that in a long time, that it might be something that's coming back or is related to a prior problem. So really having a long discussion that pertains to your particular specific history would be important. But also you could, there's certainly an amount of concentration that may play a role too. So if it's possible to address that, that might help as well.
Okay, have there been any studies looking at tinnitus and vestibular and falling problems?
That's a great question. There have been a lot looking at hearing loss, but nothing that I know of, and that doesn't mean it doesn't exist, but that's right on my brain. I'm looking at my hive mind here. No one else knows of any tinnitus and falls correlation. We know tinnitus is closely related to hearing loss, obviously.
Is nausea often or occasionally connected to dizziness?
I'm sorry, is the question someone has nausea connected with dizziness?
I guess, is that connected with dizziness?
It certainly can be. And one thing that's really crucial is to have someone, if you're having dizziness, look at your specific medical history. We kind of glossed over a lot of things that could play a role, such as medications you're taking and other important other health aspects. So they can be related, and it's important to get that investigated.
Next, is there any medication for vertigo?
Oh, that's a fabulous one. Thank you for asking. And all of us are cheering in the background for that question. So most of our patients, I would say both Andrea, myself, and Jennifer, get patients whose medicine, their pill for dizziness, typically called meclizine or Antivert, is not helping them. In fact, that medication doesn't really treat balance problems. It may reduce your symptoms. It may make you feel tired so you could sleep until your symptoms go away, but there really isn't a pill per se. That being said, for many vestibular problems, we do give some medication. Water pills for Meniere's is a great example. So there might be some individual medications or even stopping medication. That's the right thing to do for dizziness, but there's no pill. And often people who are told Antivert, that's not accurate.
Okay, next, I list to the right when I walk. I also park my car a little diagonally. Is this related to my balance problems?
Let's have Jennifer take that one.
So that definitely can be, and that is a very common complaint, the listing to one side when you have a vestibular problem. So if one ear is quote unquote stronger than the other, you will feel like you're being pulled in that direction. And that way people say they list or they feel like they're tilted to one side. I would also recommend that if you feel like you're parking or if you're tilted like that, that you just make sure you get your eyes checked, because sometimes that can be an influence, sometimes with cataracts, or if you have a problem with depth perception or anything like that. So I would also rule that out as well.
Thank you. I've had vestibular rehab, yet I still get mild dizziness and vertigo when I sleep on the right side. Is there any new research or specific exercise for this?
So I would say if you're still, so vestibular rehab is effective in more 90% effective. So you're still going to have some residual symptoms, but I will say that if you're having positional symptoms like that, that there's definitely exercises out there that you can do that will be effective and help with that, specifically the positional dizziness. So I would say, I would recommend for that person to go back to vestibular therapy to see and to actually make sure that they don't have BPPV, which Andrea spoke in depth about, because that's a pretty common complaint and that is an easy treat for those symptoms.
Have you assessed whether staying in our homes, apartments for many months due to COVID may cause balance problems once we go outside, especially in disorienting New York City?
You're good if I take it. Yeah. Yeah. I mean, so I think I know that I'm seeing this in a lot of my patients or patients that we're seeing in the clinic. We call it something, it's something called decompensation. So before COVID, you were outside, you were experiencing the world, and you were kind of doing your own therapy. You were outside, there's, you know, a lot of noise, a lot of visual influence, and then you stay inside and you don't move. And we know that if you stop moving, that your balance problem will become worse. And we are seeing this. We haven't specifically studied this, but I'm looking at Dr. Cosetti and we're thinking that this is probably a good topic for our research to take a look at, but we are seeing this very common with our patients.
Thank you for all your knowledge. If you have the ability to train other medical professionals, please do. I had a bad vertigo experience after a flight to Florida 5 years ago, and the facility I went to, emergency room personnel and various doctors I saw knew nothing about about vertigo or how to treat it other than some anti-dizzy meds. No one mentioned BPPV or the Epley maneuver. Could you please explain that Epley if there's still time, and how do we find a specialist that knows how to do that?
So I feel your pain. I know that when I started doing this, there was even less medical professionals who knew anything about vestibular disorders. I would say that if you are experiencing any of these symptoms, the specialist that you should go see is a neuro-otologist. If you're looking, or, you know, we're very lucky here that we have Andrea, who's a nurse practitioner who specializes in dizziness. They will help you and kind of guide you through the process and hopefully refer you to a vestibular therapist who can help you with the Epley maneuver. So I think we have a little time to talk about it, John. Briefly.
Okay. We've got there are lots of questions. We're not going to
okay.
get to them all, but if there's something you want to talk about, by all means, go ahead.
Sure. So just in terms of the Epley maneuver is a general term that people use for treatment of the most common cause, the most common BPPV that occurs. And so Andrea talked a little bit about how we test for BPPV, but to go through the treatment, they have to, or the practitioner has to put your head down over typically a bed or a mat, and they have to trigger your vertigo. And that is the most important thing to remember, is that going through this treatment, your vertigo will be triggered. And I think that's the hardest thing to do because it's a really unpleasant feeling. And so the therapist or the doctor or nurse practitioner will bring your head down over the mat or the bed and kind of keep you in one position with your head turned for about a minute. The next part of the treatment is then turning your head to the opposite side and waiting another minute, and then rolling you over onto that side and waiting another minute, and then having you sit up. And that's in general what the Epley maneuver is. There's also, so just to say, I know that some people are talking about Facebook groups. There is, for the American Physical Therapy Association, you can look up specialists who, you can look up PTs who specialize in vestibular rehab based on zip code, and that can be very helpful.
Thank you. The next question, I'll cut part of it, but is there a relationship between stress and episodes of dizziness?
So when we talked a little bit about decompensation, so stress is one of the things that will prevent your brain from kind of relearning after any kind of vestibular problem. I'm looking in the chat too. If you have like Meniere's or migraine associated vertigo, this will be something that can trigger those episodes. So if someone can figure out how to decrease stress, you let me know.
Is there a diet that can avoid vertigo? Sometimes when I eat salty foods, I notice some dizziness.
Okay. Yeah, so I think, you know, salty foods is definitely something that we encourage our patients to avoid. We also have them avoid caffeine, can be a trigger for some people. When you start talking about a migraine diet, you start talking about chocolate or wine or anything that has a nitrate in it can be some of the triggers for vertigo.
A friend with hearing loss mentioned that she has trouble when people eat on a Zoom meeting, and she said it's because she has vestibular issues. It bothers me too. What is the link?
So what I think the link is that when people see a lot of visual movement on a screen, and so when you eat, you move your mouth and you move your head, that tends to be a trigger for people who are dizzy, because when you're dizzy, you are more reliant on your vision. And so if you see a lot of things moving in your environment, your body thinks that it's moving, and that causes you to feel dizzy. And that's a common complaint that we hear with a lot of people is when people move around me or when I watch a busy show or a busy background, that really makes me dizzy.
Another medication question, and I may mispronounce this, but how about amitriptyline? I was prescribed this by a neurologist in consultation with my ENT.
Definitely, that sounds like an appropriate medication. The part that I liked most about the question was it said in consultation with their doctor and their ENT. So that's the key. There's a lot of medications out there. That's an appropriate one for a variety of causes of vertigo, including migraine related.
Next question is, do you recommend self-treatment for the crystals?
We got to take this one.
I'm back. So this is one of my biggest pet peeves is I think there is a place for self-treatment of the crystals or BPPV. I think that you have to be really trained to do it correctly. I personally have seen many people who have done the exercise based off a YouTube video or another therapist, and they have made themselves worse. And so I would say you have to be really careful doing this. And I would always recommend seeing a vestibular therapist first. And if that person thinks that you should do a self-treatment, then go for it. The YouTube videos out there are, as we know, many, and they have a big variety of what the treatment would be. The first thing I always tell patients is, how do you know which side to treat? And most people tell me, I do both sides. But that's extremely uncommon to have it on both sides. So it's really important to see someone first before you decide to do a self-treatment.
Is it worth pursuing treatment if you have had severe Meniere's with bilateral vestibular dysfunction, vestibular migraines, and severe hearing loss, cochlear implant for over 15 years? Tried VR once, not great. My vestibular symptoms were severe when I left each session.
So I would say it's important to go to someone who will monitor your symptoms afterwards. I would say you probably need to go really slow. There's a lot of things going on there. So one of the things that we always talk about where I work is talking to your patient about how they feel after the session. If the patient feels worse, you have done too much and you need to scale it back. And I would say that you probably the therapist needed to scale it back for you. But we have a lot of evidence out there that shows that even with all those problems, you can still have benefit from vestibular therapy.
How important is it to keep doing the exercises after completing a series of vestibular therapy?
So what we normally tell people is for maintenance, a lot of my patients like to do it every day because they just like to do it. But typically you just need to do it a couple times a week for a couple months afterwards. If you find yourself kind of slipping back, restarting the exercises every couple days can be helpful.
So I think we're going to have to stop with the questions now, and many thanks to all of you. It was a wonderful presentation. It seems to have generated a lot of interest and a lot of discussion. It's an important topic for many of us, those with or without hearing loss, but particularly with hearing loss. I'd also like to thank David Landsberger for being our Zoom host. And as always, special thanks to our superlative captioner, Lauren Schechter. I would also like to acknowledge my son, Jun, who did the wonderful illustration on the announcement of tonight's meeting. It was great to see so many new faces. To learn more about HLAA or to donate to help us continue our activities, please go to the chapter website, hearinglossnyc.org. The topic for our next meeting on March 2nd will be whatever happened to over-the-counter hearing aids. Kevin Frank, Vice Chair of the National Board of Directors of HLAA, will discuss where we are with OTC hearing aids. In addition to discussing who the aids are intended for, issues about labeling, places of sale, he will answer two important questions. What are various interest groups, including HLAA, hoping to see in the regulations? What is filling the gap left by the FDA's failure to regulate? Before we leave, there are a couple of other Zoom events I would like to mention that may be of interest, though I have no firsthand knowledge about the speakers. At the first, Sal Gentile, a support group leader with the American Tinnitus Association and a tinnitus coach, will be guest speaker at the Treasure Coast, Florida HLAA Chapter's virtual meeting at 10:30 on February 6th. He's a tinnitus coach with audiologic training and will talk about his life experience with tinnitus. To get information on logging in for the Zoom presentation on Saturday, email treasurehearing@gmail.com. And the second one is on February 12th rather, from 12 to 1:30, the NYU Center for Disability Studies will present the topic, Deafness and Hearing in the History of Science. Several authors will discuss their recent books. One is entitled Hearing Happiness, Deafness Cures in History. The second is Testing Hearing, The Making of Modern Orality. For more information, go to http://disabilitystudies.nyu.edu/events. So thanks again to all of you for coming. It was a great meeting. Stay warm and stay safe. And I'm hoping that Punxsutawney Phil has predicted a spring coming soon. So good night to all.
Thank you all.
Thank you.
Thank you.